All right. Okay. So, welcome to Heart Talk Tuesdays. I have a special guest for everyone. This episode, we're going to talk about the Hantavirus. Of course, we're always going to add a link to heart disease, but this has been on a lot of people's minds just because of hearing about these folks on this cruise ship. And a lot of us want to know, what is Hantavirus? Is this going to be like COVID? How can we get information? So, I couldn't think of anyone better than my mom, who is an infectious disease specialist for over 40 years. She trained at Case Western University and has been practicing since HIV all the way to COVID, even till now. And for all of that time, she's been an advocate for her patients. She has always stayed up to date with all of the information. In addition to that, has always been a servant to ensure that all of her patients get equitable care. So we are so lucky that we have her as our guest today. So we will begin. And you all know me, I'll edit that part out. You all know me, I'm a cardiologist. I work in rural Kentucky, and we're going to get right into it. So, Mom,
Yes, thank you, Dr. Mary.
what is hantavirus?
So, hantavirus. Hantavirus is a virus that, interestingly, we've known about since about the mid 90s. I remember, I was long past my fellowship, but we heard about this virus that was this disease that was infecting people in the Arizona area, Utah, New Mexico. And, as most diseases, trying to figure out what it was. In those days, we didn't have PCR like we do today, polymerase chain reaction, those molecular tests. So they finally were able to identify it and give it a name, hantavirus. And it's been a subject of a lot of board questions and so forth. So it's been around for that time. And the reservoir, meaning where, because viruses are like parasites, so they have to cling on to something. They are
Mhm.
found in rodents, mainly the deer mice. And so, every now and then, over the years, we've had cases of hantavirus out in the southwestern area, but this is new because there are about maybe 40 different strains of hantavirus, and maybe only 15 to 20 affect humans. But this particular strain, called the Andes strain, and what the way that people historically get infected is by, rat feces, saliva, rodent droppings, and those kinds of things. As I mentioned to you earlier, people remember Gene Hackman and his wife were found dead in their home, and she died of hantavirus. But this
So how did she? I mean, so that means she somehow was in contact with rat feces.
Well,
I mean, did
they
it get
lived
in
on a
her
farm.
food?
They lived on a farm, and let's
Mhm.
postulate that she was cleaning out the shed or cleaning out,
Oh,
that kind of area where the virus can now get aerosolized and enter your, nasal passage, and you come down with a lung infection, which is has a significant high morbidity and mortality. The mortality with lung hanta is around 40% ish.
mm,
So this particular Andes virus that they found in on this cruise ship spreads person to person, and that's what made it so dangerous in
mhm,
terms of people being concerned about it. Because anytime you have a virus like COVID that
mhm,
spread person to person, you have
mhm.
the propensity to infect a lot of people in a short period of time.
So
So the hoopla about this.
do you think those people who were on the ship got exposed before they got on the ship? Somehow somebody was with rat feces in some way,
Well,
and then they got on the ship and were sick and didn't know, and then they spread it.
it's hard to say because by the time they found it, they were so busy trying to keep these people alive that I don't think they did a lot of contact tracing initially because they didn't really even know what it was. I mean, the first person came down with a symptom on April the 1st and then died April the 11th. So they were like with us in COVID trying to find out what was going on. And then when they finally realized that, so we don't know, we think that this Dutch couple went bird watching in a landfill in Argentina, and and acquired it there. The
Mm.
Andes strain is endemic in that area. I don't know, we don't know, we haven't been told, let's put it that way, how many other people were with them, or if they were with them, or if they were in the environment. But what we do know is that the people on the ship have come down with the same strain.
Mm. So the Andes strain, can you talk a little bit about, so there's different strains. What I was reading was there's this renal strain that's a hemorrhagic fever.
Right,
And then there's also this pulmonary strain, the Andes virus.
right.
Why is this so dangerous and how does this compare to COVID? Is it similar mortality? Is this worse? Do we know yet?
Well, I think there's a lot we're still learning about this. The good news is, in terms of how COVID spread so fast, like I said, it was person to person spread. The hantavirus, some viruses adapt to attacking human organs very well.
Mm,
COVID-19 was especially adaptable for doing that. Viruses like hantavirus, they just haven't quite gotten that able to attack to the lungs and become person to person, so that it's an efficient respiratory spread is what I'm trying to say. It's
mm,
not an efficient virus for respiratory spread. It's an
mhm,
efficient virus for causing, the malaise and the fever. You mentioned the renal hemorrhagic syndrome that's a part of
mhm,
this hanta. But the person to person, those of us that are in infectious diseases, not too many things scare us. And so when we started hearing about COVID-19 spreading from person to person, and I knew early on that it couldn't just
mhm,
be droplet, because the number of people getting infected was logarithmic. And it's
mhm,
the same.
mhm,
I remember having an old infectious disease mentor who said that, John Bartlett, whom a lot of people of my era remember, he said the thing that scared him the most in infectious diseases was bird flu. And so even today, bird flu is still not an efficient virus to become respiratory spread. When
mm.
it does, we're in trouble. So that's the issue. You have a heightened sense of awareness. Your hair stands on your head when you start hearing about person to person spread, and the mortality is so high.
Mm. So before it was going from, I guess, zoonotic, what do they call it? It's animal to
Right.
animal, but
Animal to
now it's
human.
animal to human, and now it's human to human. And that's when
Exactly.
it becomes
Exactly.
something that's concerning. Do you
Exactly.
think that it genetically has mutated or,
That's an excellent question
has
that
it
we're talking
evolved?
about. Yeah, that's an excellent question because, um, that's not my area of specialty, but I am an
Mm-hmm.
infectious disease person
Mm-hmm.
over a long period of time. I'm thinking and wondering if climate change, the adaptability of viruses, climate change, those things that happen in the environment are causing these. We know that in order to survive, viruses have to mutate. They're going to survive. So they're going to find some place to attach on for to continue to live. And so if, because of climate change or those kind of other things that are global warming, all those other things that are happening in our environment, I think that everybody, every scientist is starting to look at this now. Because as
Mm-hmm.
they say with the old song, something's happening here. What it is ain't exactly clear. So,
What's going on? Like
yeah,
Marvin Gaye.
yeah, yeah.
And you have conspiracy theorists that think, is someone manipulating this, but you're saying that genetically this is part of evolution,
It
that
is, I
viruses
believe. Yeah.
adapt. So that doesn't necessarily mean that there's a human that's trying to do this
Right.
to us, but that viruses have adapted over time
Right.
to become more virulent to survive, just like we've adapted to try to survive.
And that's the function of vaccines, is that when you immunize people, the viruses run out of places to go. So
Mhm.
that's the success that we've had with a lot of viruses in making those pandemics go away.
hmm And vaccines are always a hot topic. I'm in rural Kentucky. Nobody believes nothing. They ain't
Right.
doing nothing. They ain't getting no vaccine. They ain't doing nothing.
Right.
But and I understand that if a vaccine is new, I understand the concerns that they have. And I get that because they don't know what they're putting in their body, what are the impacts. And we do know that with COVID, I mean, there were small cases of myocarditis related to the vaccine itself. We saw in sort of younger males typically. We don't know the implication of that because it wasn't fulminant myocarditis. It was just some inflammation that we found. So, I understand the concern. But with the vaccine, does that keep people from getting the virus, or does that keep people from getting sicker if they contract the
Yes,
virus?
the vaccines, well, let's talk about COVID
Yeah.
specifically, because the others are preventable, but the
Hmm.
COVID-19 messenger RNA vaccine was never meant to prevent it.
Hmm.
It's to decrease deaths and hospitalization. And that's what it's done. Decrease deaths and hospitalizations. And period.
Hmm.
So, going back to the COVID era, I was listening to Dr. Birx, who was the doctor during the big COVID pandemic. And, we got a lot of things right and we got some things wrong, but we were basically flying by the seat of our pants. I remember, telling you, you come in and this was a novel virus where people were sitting up in a chair with oxygens of 50. We'd never seen anything like that. And having to rush them to the emergent, to the ICU, not having enough ventilators, not having and doctors, you know, getting PTSD. I mean, it was a nightmare. So we're looking back now. It's been almost 6 years, and but the lessons learned, we're still learning, and that's what bothers me. That I'm not sure we've quite got it right yet.
Right. Yeah. And so, you were there since before HIV, before we knew what it was. And then you would go into the rooms of patients who had AIDS, and we still didn't quite understand it. And you were still on the front lines for COVID. Does anything scare you?
Um, multi-drug resistant tuberculosis. If I had to pick one,
Yeah.
multi-drug resistant tuberculosis, because the drugs are wretched and it's really hard to treat, and multi-drug resistant Mycobacterium avium, those two. But, as I
So what
often tell people,
when you were, treating these patients, what was going through your mind in terms of how you needed to protect yourself or how you wanted to advocate for those who maybe didn't have someone, an advocate there for them because they were treated, as lepers. And I think, that
right.
happened with HIV and COVID. So was there something that motivated you to want to, stand up for these people or continue to treat them and support them?
Well, I've always been a patient advocate. I stand on the shoulders of my mentor, Dr. Charles C.J. Carpenter, who you've heard me talk about a
And
lot.
he's from
He's from Birmingham,
Winston-Salem.
Alabama.
Oh, Birmingham. Okay.
Yeah, he's from Birmingham, Alabama, and he went to Hopkins and then he came to Case Western Reserve.
Mm.
And he became my mentor, and he drilled in us this thing about be your patient's advocate, because basically you're all they have, And so when the COVID pandemic came around and we had to start wearing all this protective gear. Remember, with Ebola, I remember I was working for University of Pittsburgh Medical Center, and we had to go to some central place in Pittsburgh and learn to don and doff protect PPEs at that time. And that was dangerous, where you didn't even want skin or anything showing. And COVID around that time, when we didn't know how it was spread, I remember the nurses saying, Dr. Banks, there's a little piece of your neck showing. I guess I just felt that this is what I signed up to do. And the microbe hunters, and we've always been the front line of it. I often tell people, if I was scared of what I was doing, then I wouldn't be able to practice efficiently.
Mhm.
So you just can't worry about. And we lost a lot of healthcare workers. Don't think that I didn't think, though, every day we had to come in and get our temperature taken. And we knew that if you had a fever, you were probably toast, because that's
Mhm.
just how it was before the vaccine.
Yeah, I had a co-resident, in COVID, I was cardiology fellow.
Mhm.
And one of the residents, someone I did residency with at Chapel Hill, his wife died of COVID. And we were in, the same class and having two physicians at
Mhm.
home. And, Olivia was just a baby.
Mhm.
But we followed all the precautions, and thankfully we had, Dr. Fauci and at least someone saying
Right.
these are things that you can try to do to try to limit exposure of the virus. So
Right.
we take our scrubs off, leave them in the garage, and Olivia was separated. Thankfully, we had the means to have someone take
Yeah.
care of her.
Yeah.
And we, kept that distance as much as possible. And thank God she never got, COVID during that period. Thank goodness we had a really good, support and nanny who helped
Right.
take care of her during that period. But, it is scary because you don't know. And sometimes you get that PTSD because it was, could this be it? But to your
Yeah,
point, if you're on a mission from
you
your
signed up
mentor,
for it. I think for us, though, it was even more. And when we start hearing diseases like Ebola coming back, possibly, or these, hemorrhagic fever and so forth, it was that our own protection, but we had to deal with death and dying a lot. And when I went into infectious diseases, I didn't want to deal with death and dying. And then HIV comes along. I never wanted to do oncology. ID was a happy feel, antibiotics and you're
Mhm,
up the next day. And then I'm smack dab into HIV and then Ebola and then all
mhm,
these other things. And we had to deal with patients on ventilators that we knew weren't going to make it, that couldn't see their families. I mean, it was just a whole conglomeration of trauma emotionally,
And I
trying
remember
to.
you used to draw the patients, your HIV patients. Was that helpful as an outlet?
It was. I named my drawings The Pathos of AIDS, and
Mm,
that was really helpful because I was able to express the pain and suffering that I saw with my patients when the drugs weren't that good at that time. So that really helped. And the good news was I stopped doing that because I lost my subject matter because everybody was living. Those
mhm.
days of the pathos of AIDS, at least in developing countries in the United States, were pretty much over.
And you were part of that.
Yeah, yeah, I was.
So, sometimes it must be a service given from God that we
I
are
think so.
given, and it's can be a heavy weight, but it's, our service. So, getting more into it. So you talked a little bit about the mortality rate being close to 30 to 60%, which is quite high.
Mhm.
And the pulmonary component, you can have pulmonary edema, you can get fluid in the lungs. And as a cardiologist, of course, I have to mention the heart component to it. So, when your immune system is just revved up because you have this virus and your immune system trying to figure out what to do, and it's just kind of all hands on deck, your T cells can attack your heart. And you can get inflammation of the heart, and you can get something called myocarditis. And the reason why that's a problem is because myocarditis can become something called fulminant myocarditis, which means you develop heart failure. Your heart pump fails. And if you don't get immediate treatment, you may have to go on what we call mechanical circulatory support, where a machine is just circulating blood through the body and supplying oxygen and trying to do the job of the heart and the lungs. Not every facility per se may have this capability. We do in rural Kentucky, but it's hard for us to manage it. And we would have to send those people to the University of Kentucky for continuum management. So, and there are smaller hospitals that may not be able to provide that kind of support. So that's where I think in certain areas the mortality rates may be higher, is because they may not have that equipment to keep
That's
people
right.
alive. And the
Mhm.
myocarditis component can be very dangerous and can be deadly. So what are the signs and symptoms of hantavirus? I'm sick right now. Do I have hantavirus? What's going on?
Well, first you should have some index of suspicion that you've been in an endemic area. However, I mean it's really sort of as they call it protean, fever, chills, malaise, diarrhea, all those kinds of things, and you really don't go into the fulminant aspect of it until later. The incubation period for hantavirus, which is another thing that's been troublesome, is a week to 8 weeks. So when you're
Mm,
talking about quarantining people and waiting to people till until people become symptomatic, you're already behind the gun. So, it's just can manifest itself as just some average there's nothing, no, like in meningococcal disease, there's no specific rash, no, things in infectious diseases that where a rash will let you know that this is just upper respiratory. Now, if you get into other aspects of it with renal disease and so forth, you're going to start having, when you do lab work, start seeing manifestations of renal failure or maybe even some bleeding. But,
Mm,
initially, and this is the problem by the time you really identify what you think this might be, like the Hanta and Ebola, you're already behind the gun because
mm,
you need to start doing contact tracing. And I was listening to Dr. Burks today talk about how, when you do public health, a lot of times you're just testing the people that are symptomatic. You have to test those people that have been exposed to see when they turn positive or if they turn positive. That's how you get your arms wrapped around it.
mm. So that doesn't make me feel any better. Is there, so I think the folks that they were who were on the ship, some went to Nebraska, some went to Emory, and Emory was one of the places that was equipped for Ebola back
Right,
then, I think 11 years ago or so.
right. And
And they
Nebraska too.
in Nebraska, and oh, okay, and they quarantined them for I think it was around 42 days. Is that enough time? You think for that
Well,
type
they're
of quarantine?
offering these people 42 days. That should be enough time based on the epidemiology of what we know. The problem is that we are coming from COVID-19, where people felt like a lot of their rights were taken away, and there wasn't a lot of data to support a lot of things that we did, shutting schools down and, shelter in place. And so, what I have said in commentaries that I have made is to mandate that people stay in isolation. You can't mandate that. And that's
Mm,
going to be a problem in trying to keep people quarantine. That we're into this rights mentality now, not so much public health, and a lot of it was based on a lot of misinformation, disinformation. Messaging is important, and when
mm,
people all are confused, they'll take the pathway of least resistance. Well, I'm not staying here. You can't make me stay here. So
mm.
there you go.
So a hantavirus, you're saying unlikely to be like the COVID pandemic, but let's
Correct.
say there is another pandemic. Are we ready for another pandemic?
Categorically no. And I will say that because, some of those lessons that I told you about learning in terms of testing and so forth. Well, first of all, if we talk about the United States, we're in a different situation now. We don't really have the leadership that we had during the COVID pandemic that kind of jumped in there, got in there. They were on television every day telling us what to do. We don't have a CDC director, and the person that's leading the CDC hantavirus campaign is a urologist. He's not really a public health person. We don't have an FDA chair. We don't have, and then a lot of money's funding was taken away.
Mm,
When you talk about research and development, you need money. And so basically, first of all, we just don't have leadership right now. When I go to the CDC website, which I just did before I came on here, because I'm hoping every day there's going to be something new, it's just basically not much at all. And
mm,
our information is coming from WHO. Well, we got out of that last year. So, I'm pulling down just for to try to be the trusted messenger in my area, WHO information, and today we find out that they implemented, I believe it's called Title 42, where they shut down the borders. And
mm,
WHO says, well, that's not necessarily proved to necessarily be effective in a country where you don't have it. I mean, it's different where, like Ebola, where you have Uganda and all those
mhm,
countries close to each other. But when you're talking about flying by the seat of your pants doing stuff, well, hey, we're not part of WHO. Um, and that was important because this was a cruise ship that was not in United States waters. So, just so your audience knows, that group from the CDC that would have been deployed to do cruise contact tracing and all of that, they were let go last year.
mm. So I'm wondering if we have to be, maybe utilize, like, let's say if you're active on LinkedIn or Twitter, do you have contacts in infectious disease in other countries that you can maybe circumvent the WHO and continue to receive information
Well, I
from
think
these countries?
WHO is still a very viable, an accurate um, site to go on. I wouldn't say that, there's some others that I don't really know specifically that I would necessarily hang my hat on. World Health Organization is pretty tried and tested.
Hmm.
And so I rely on them. I go to them because that's about all we have.